you guys see my screen?
Yes, doctor.
Yeah.
Make sure you're seeing the right screen. Okay, that's what I want you to see. Okay. Okay.
So
Should I start?
let's give everyone, let's
Couple more minutes.
start at 4. Give everyone a bit more time to join in.
At 7 a.m. that I realized.
No worries.
Hello.
Morning.
Good morning.
Hi. Good morning.
Good day.
Morning.
Hi, Dr. Sangvi.
Hey, good morning.
Hi, great to have you.
Oh, thank you. Is everyone ready?
We may give us a few more minutes.
Okay.
I think we have over 35 participants total enrolled in the course, so we'll see how many join.
Oh, hey. Ben, yeah.
How is everyone in the Philippines? Maybe we can start by, sorry, what was that? Maybe we can start by typing our name and what center we're from in the Zoom chat box, so Dr. Sangvi can see. Great, and Dr. Sangvi, you can see the chat box okay?
Yeah.
Good, welcome Jafar. Hello Mark, Katrina, Dustin, John, Valerie, Candice, Rosalea, Miguel, Angelo, Edwin, I recognize, Nixie Paul from St. Luke's, welcome. We have Benedict from Perpetual Health, Jason, excellent, and I see we have some more participants, up to 32 now. Welcome, Vince. Hi, Stephen. Good, thank you everyone so much for completing the enrollment form. That was very helpful for us, and we can see what year and training you are and what your background is. And also helpful to see, looks like many have experience with nasopharynx cancers. We'll definitely try to cater the course so it can focus on diseases that are relevant to what you see. And we'll also try to focus on the areas where it looked like people were most interested in trying to improve their skills. And Rochelle, feel free to put on your microphone if you wanted to say anything.
No, I just want to say hi to everyone. It's nice to see them, all of them.
Good, well.
Looks like we have a good number of people. I think this should be almost everyone.
Okay, excellent. Hi, Rich Murray. So I'll go ahead and start with the introduction since this is our first time doing a session. And Rochelle also will be helping throughout this course with providing introductions to the speakers and helping to answer questions as they come up. This is meant to be a very safe space, so feel free to type in any comments or any questions that you want. We have found that the more that people type and are curious about anything, even if it seems like a silly question, the better and more exciting the sessions are. And the chances are, if you have a question, there's probably someone else that has the exact same question but maybe is just a little too shy to type it. So it will be helpful for everyone. We have a very exciting first session to kick off our Philippines head and neck contouring and plan evaluation curriculum. It's my pleasure to introduce Dr. Parag Sanghvi from University of California, San Diego. UCSD has a rich history of innovation and excellence in cancer care. And in particular, they're interested in trying to connect with other centers in different parts of the world, interested in collaborations and trying to promote high quality education and training so that cancer care can be provided excellently in all areas of the world. We have to stand up and look out for each other in radiation oncology because we're very small compared to other fields, but I think there's a special power in being small and feeling united. So without further ado, I'll let Dr. Sanghvi introduce head and neck cancer.
Hey, good morning, everyone in the Philippines. I want to thank Ben and Rochelle and Kakoa for involving me in this great enterprise. So I'm really thrilled to be here. And as Ben mentioned, I really want this to be a very interactive course. So please feel free to ask questions. And we really hope that this is a iterative process for all of us, and we can just really cater to whatever your questions and needs are as we take care of these very complex head and neck cancer patients. So it's really my pleasure to be here to talk about this. So I always start with this for head and neck cancer, because I think all areas in oncology can be taxing and complex, but I think head and neck is one of those disease sites that really requires such a careful attention to detail in every aspect of a patient's journey through their cancer. And as an oncologist, you're constantly making decisions. And each of these decisions, as trivial or small as they may seem, can have some really meaningful consequences if everything goes well, and some very disastrous consequences, as we all know, when things don't go well for our patients. So I wanted to kind of start by just sharing a couple of cartoons. So here you go. I hate making decisions. Just remember, choosing not to choose is a choice. So by also not doing anything, I'm actually doing something that's great. And then, oftentimes as when you're in the depths of contouring and trying to decide what to treat and what not to treat for any given patient, sometimes those decisions can seem a little arbitrary, like rock, paper, scissors. So my hope and our goal really is that by the end of this course, that each one of us feels a little bit more confident in our abilities to take care of these patients. So I would say that, I was trying to think of how we wanted to outline this course, and I wanted to keep it very simple and relatable to all of us. And so I would say here are the objectives that I think we all think of as we take care of these head and neck cancer patients. When do we treat them? How do we treat them? What do we treat them with? And if you decide to treat them with radiation, how do you evaluate that your treatment plan is appropriate and adequate for the care of your patient? And then finally, I think one of the areas that I really hope that we will spend a little bit of time on is how to anticipate and manage side effects of our treatments. I think we all realize, particularly in head and neck, that not only do we put people through a very challenging challenging course of short-term side effects, acute side effects during the course of their treatment, but many of our patients survive and have to learn how to thrive with long-term deficits from their cancer and their cancer therapies. So we'll hopefully spend a little bit of time for that. So the first couple of slides are pretty basic. When do we treat? I think we all know that particularly in head and neck cancers, radiation oncology is the center stage. It is the main modality for almost every single cancer patient whose journey you're going to be a part of. So when I think of the role of radiation in a definitive setting, certainly nasopharyngeal cancers, oropharyngeal cancers, larynx and hypopharyngeal cancers, particularly when the goal is to do larynx preservation therapy. And then a big part of our practice here in San Diego is skin cancers. We see a lot of skin cancers here, both non-melanoma skin cancers and melanoma and Merkel cell cancers. And radiation has a pivotal role in the management of these patients. particularly in advanced stage when patients present either with regional nodal disease or with perineural invasion. And I know that we have a talk, going to talk about PMI. And then thinking of radiation in the adjuvant setting after surgery, really the oral cavity, nasal cavity, paranasal sinuses, salivary glands, some locally advanced non-melanoma skin cancers, particularly if they have a regional nodal failure, thyroid cancers, Merkel cell and melanomas. And then I would say that in oropharynx, there's especially with the advent of better surgical techniques, particularly robotic surgery, and recognizing a truly a new subset of head and neck cancer patients who present with HPV-mediated oropharyngeal cancers, there is a movement, and a successful movement to treating at least a small cohort of patients, early stage patients with primary surgery. And there's a lot of interest in attenuating, both chemotherapy and radiation in these patients when safely possible. Just this weekend, the American Society of Clinical Oncology, the early results of ECOG 3311, which was the randomized trial for patients undergoing TORS robotic surgery and followed by adjuvant radiation. So those results are going to come out, and all those results look really, really promising. So I do see that surgery will play a big role in the management of early stage oropharynx cancers. So thank you everyone for taking the survey. I think we realize that nasopharyngeal cancer is endemic in the Philippines, and you guys, everyone there treats a lot of these patients. And so I wanted to start with a case where I know that you guys do a lot of and do it well, so that we can have a dialogue about how to manage these patients. So this is one of my patients, a 52-year-old who presented with, basically oligometastatic EBV positive nasopharyngeal cancer a couple of years ago. He presented with basically a single liver metastasis. He had one liver metastasis at the time of presentation, which was biopsied. He had fairly locally advanced disease. So he had a tumor in the nasopharynx, extending into the sphenoid sinus, extending into the nasal cavity and the pterygopalatine fossa, and then going into the middle cranial fossa. So it was really, and this tumor was biopsied and it was EBV mediated. And given the locally advanced nature of this, his disease, our recommendation was to start with some induction chemotherapy. And we'll talk a bit about that. This is probably the only head and neck cancer where we still talk about induction and adjuvant chemotherapy, as there clearly is a role for chemotherapy besides in the concurrent setting for these patients. So this patient got 3 cycles of induction chemotherapy, had a phenomenal response, and had 3 cycles of basically cis-docetaxel, had a phenomenal response, had significant improvement in his liver metastasis with significant involution, but also involution in his primary tumor. I wanted to show you what his initial imaging looked like, so you get a sense of this. So you can see this very bulky mass, basically filling the nasopharynx, extending into the clivus, extending anteriorly, into the pterygopalatine fossa and the posterior part of the nasal cavity. He had multiple nodes, bilateral neck nodes. You can see, a retropharyngeal node, and then it's a bilateral cervical adenopathy in the level 2 neck in this patient. And when we talk about diagnosing these patients and working these patients up, oftentimes, depending on where you are, some patients only get a CT of the head and neck with contrast, which is a reasonable, it's a reasonable diagnostic scan for a lot of head and neck cancers. But nasopharynx, I will say, truly is one of those exceptional cancers that requires additional imaging, where MRI and a PET scan really complement a CT. And I wanted to show you that here. So here you can see in this patient, you can see that there's uptake here in the clivus. And when you do an MRI, you can see extension right into the clivus here for this patient. And you can see disease going into the middle cranial fossa, into the bilateral cavernous sinus, but particularly here on the right side. And so very extensive disease for this patient. So just wanted to talk a bit about the clinical presentation for most nasopharyngeal cancer patients. I think you all know this very well. I won't spend a lot of time on it. These patients, as we know, often present with neck adenopathy. They can certainly have local symptoms from their primary tumor, causing nasal congestion, nasal stuffiness, and if they're locally advanced, even sometimes epistaxis. I think one of the most common symptoms that we see for lots of head and neck cancers, including nasopharyngeal cancers, is really referred ear pain. In nasopharyngeal cancers, you can have direct ear pain by just occlusion of the eustachian tube, and you can have referred ear pain through some nerve pathways. But locally advanced nasopharyngeal cancer, this is one of the few exceptions where you can see patients come in with multiple cranial nerve palsies. And so just something to be aware of, that these are patients who warrant a very comprehensive cranial nerve exam when you're seeing these patients. Oftentimes, the most common cranial nerve involved is actually the sixth cranial nerve, and this is usually direct from direct local extension from a clival tumor growing in posteriorly and invading into the cavernous sinus for these patients. But patients can present with, really cranial nerve neuropathies of nerves 3, 4, V1, V2, and 6 because of cavernous sinus invasion. And for very locally advanced cancers, you can actually present with invasion, into the jugular foramen by parapharyngeal nodes, causing Villarette syndrome and Vernet syndrome, both really with tumors going into the parapharyngeal space and going into the jugular foramen. We don't see this very often in the US, but I certainly see at least a couple of these patients a year that come in with multiple cranial nerve palsies, either at initial presentation or as the sign of recurrent disease in these patients. In terms of workup, it's fairly standard, as we all know, doing your nasopharyngoscopies, doing adequate imaging, as I talked about. And then really, I think one of the things that is becoming increasingly important in head and neck cancer patients, particularly as we do such a great job of curing our patients, is really doing upfront management in terms of repetition and speech and swallow, because I'm going to talk a bit about the toxicity of cancer therapy, of radiation. Our long-term survivors really struggle with these two issues the most, and swallowing function and oral dentition. And so I think that involving these folks upfront is very important. Important nasopharyngeal cancer patients to do an audiology exam upfront. Really, this often impacts not the decision of the radiation oncologist, but oftentimes from medical oncology, given that really platinum still seems to be the pivotal chemotherapy agent that we give most nasopharyngeal cancer patients. So having baseline audiology exam becomes important. In the Philippines, I imagine just like the rest of Asia, majority of the nasopharyngeal cancer patients are EBV mediated. And in those patients, we know that EBV titers, both pre-treatment and post-treatment, so titers done 2 weeks after therapy, seem to have a strong prognostic influence in terms of long-term outcomes for these patients. So if you are able to convert these titers to undetectable within a couple of weeks after therapy, those patients do far better than patients who have a detectable EBV DNA post-treatment for these patients. Again, another study kind of confirming that patients who have high level of pre-EBV titers, it is extremely predictive of overall survival. Those patients don't do as well, both local, regionally, and primarily in their risk for getting distant metastatic disease in these patients. In the US, we see a different etiology for nasopharyngeal cancers. About a quarter of the nasopharyngeal cancer patients in the US actually tend to be HPV mediated. And there is now good retrospective pathology data to suggest that either an HPV mediation or an EBV mediation are almost mutually exclusive. So if you are EBV negative, it is worthwhile, particularly in the Western Hemisphere, to do an HPV test to see if this tumor is HPV mediated. And generally, patients who have an HPV mediated nasopharyngeal cancer seem to do worse than patients who have EBV mediated nasopharyngeal cancers when controlled for stage. And then oftentimes, these patients also do tend to be smokers here in the US. So here's the staging. I think, again, I'm not going to spend a lot of time here talking about staging, but you have a good sense of kind of the big changes that have happened over the last 2 editions of the AJCC. When you think of T1 disease, think of just local disease involving the nasopharynx or extending just into the oropharynx or nasal cavity, but not extending laterally into the parapharyngeal space. T2 disease is really disease going into the parapharyngeal space. And now in the 8th edition, it's actually expanded to include disease going into the adjacent pterygoid musculature or posteriorly into the prevertebral muscles. T3 disease is really any skull base involvement or sinus involvement. So patients that have invasion of the clivus or sometimes for a locally advanced nasopharyngeal cancer invading into the first or second vertebral body, or patients with disease extending anteriorly into the paranasal sinus. This is T3 disease. And then finally, T4 disease is just extensive disease. So really any cranial nerve invasion, any orbital invasion, any intracranial invasion, and then any disease going laterally beyond the lateral pterygoid musculature is really T4 disease. And for the nodal staging is fairly straightforward. Unilateral nodal disease in one side of the neck less than 6 centimeters is N1. Bilateral nodal disease is N2. Anything bigger than 6 centimeters or in the supraclavicular fossa is considered N3. And so fairly straightforward in terms of. So how do we treat? I think external beam radiation has been the mainstay for nasopharyngeal cancers. I always put this slide in when I talk to my residents because I always want them to think of every modality available to you as a radiation oncologist as you think of treating your patients. I think it's very easy to be biased towards external beam radiation, but there are a variety of cancers where you can use other modalities, particularly brachytherapy, and hopefully we'll talk a bit about that, which is a great modality for early stage non-melanoma skin cancers and also for early stage oral cavity cancers. Especially when surgery is not possible, brachytherapy really provides an excellent way of improving cancer control for those patients. I realize a lot of places, I'll be curious if you guys want to type in and tell me how many of you do head and neck brachytherapy at your institutions in the Philippines. I'm curious to know. I know that in the US, it truly is a dying art. On the West Coast, there are a handful of places that do this here in the US, and I would say across the US, that's true. We're one of those places, so I have an interest in brachytherapy, and I do a fair amount of brachytherapy for both skin cancers and head and neck cancers, both in the early stage setting and in the recurrent setting. And then talking a bit about chemotherapy for these patients, again, as we all know, the primary benefit of any chemotherapy in head and neck cancer is the utilization in the concurrent setting. As you can imagine, we've gone through a couple of decades of looking at induction chemotherapy and adjuvant chemotherapy in a variety of cancers. And outside of nasopharynx cancers, that has not really panned out. So I would say that nasopharyngeal cancers are probably the one head and neck cancer to date where there is a role for either induction or adjuvant in addition to concurrent chemotherapy. And I think that this has a significant impact on distant disease for these patients. And then finally, immunotherapy. This, as you all know, is the big buzz over the last 5 to 7 years in all of cancer, but particularly in skin cancer and head and neck cancer. Immunotherapy now has become first-line therapy for patients with metastatic disease. And there are ongoing trials across the world looking at using immunotherapy in frontline therapy. So in the definitive setting or the adjuvant setting, there are trials looking at immunotherapy in addition to chemotherapy, and then there are trials looking at immunotherapy substituting for chemotherapy. So I do think that this will change the landscape of all cancer, particularly head and neck cancer, in the next 10 to 15 years as to how we treat patients. I think, again, as we all know, nasopharyngeal cancers, almost no role for surgery. And I say almost, and the reason for that being that I do think that when patients have a recurrence, and if it's truly a mucosal recurrence, there is a role for nasopharyngectomy in that setting. But outside of that, we never think of our surgeons in this in nasopharyngeal cancer. The treatment for this is truly primary radiotherapy. And this is one of the few sites where I think that we incorporate chemotherapy in earlier stages compared to other head and neck cancers. So really there is a role for chemotherapy starting at stage 2 onwards. So once you have disease going into the parapharyngeal space, we typically think of doing combined modality therapy for these patients. And so I'm going to briefly just go over some of these trials, not spend a lot of detail about these trials, but because I really want to spend most of my time talking about contouring and plan evaluation. But in nasopharynx cancer, it is one head and neck cancer that we have just a richness of trials. But the key trial that we all think of, that really established the role for combined modality therapy was the El-Sarraf trial, the Intergroup 0099, published now over 20 years ago. And this was the first trial to randomize comparing patients getting combined modality therapy versus radiation therapy. Patients got bolus platinum, which has still remained the standard of care, with adjuvant chemotherapy where they got platinum and 5-FU. They got 3 cycles of platinum and 5-FU after finishing combined modality therapy. And in this trial, you can see that there was a tremendous difference in progression-free survival in patients who got combined modality therapy. There was a lot of criticism for this trial because everybody does believe that the numbers for radiation alone are far worse than any prior single institution data. And there were a variety of reasons for that, a lot of them involving just the quality of radiation planning and delivery. But you can see that there was a big difference in progression-free survival as well as a difference in overall survival for these patients. There are other trials that have also looked at this. The other key trial that I think of is the Singapore trial, published in 2005, that looked at patients with stage 2 and 3 nasopharyngeal cancers, comparing them to, again, same regimen as the El-Sarraf regimen, so concurrent chemotherapy, and then adjuvant cis-5-FU, and you can see that there was a significant improvement in every measure: overall survival, disease-free survival, and really what I want to talk about is this distant metastasis-free survival. So patients who got more chemotherapy had a much lower rate of distant metastases. There are a variety of meta-analyses now that have looked at this issue of adding chemotherapy, and you can see that there is about a 9%, 10% improvement in overall survival in these patients, in similar improvement in progression-free survival in these patients with the addition of chemotherapy to radiotherapy. So I think we can conclusively say that concurrent chemoradiation is really the standard of care. And then this is the trial that looked at IMRT for nasopharyngeal cancers by Dr. Lee. RTOG 0225 that looked at IMRT and this was a single arm phase 2 trial. But you can see that patients were treated with IMRT based planning with really good local regional control. So 2-year local regional control rates of 93% and a 2-year overall survival of 80%. So still reflecting that, this is now a cancer where our modality provides excellent local regional control. And so the primary cause of mortality remains distant disease in these patients. And so that's where this role for additional chemotherapy comes in. So here I've kind of just put together all these trials. This was published in Lancet. The battle of more chemotherapy in nasopharyngeal cancers, induction versus adjuvant. And I feel like the pendulum swings either way, but I think it's important to remember that patients who do get adjuvant chemotherapy seem to do better overall. But the caveat that you have to take away from all of this meta-analysis is that you can't just give them chemo adjuvantly or in induction without giving chemo, without not giving chemo during the radiation. So, adjuvant chemotherapy or induction chemotherapy does improve distant control and overall survival, but that is always in the setting of these patients getting concurrent chemotherapy. And so that's the question that comes up. What do you do? When do you recommend induction and when do you recommend adjuvant? And so what I usually think of is that I think patients who truly have either T4 disease or really bulky nodal disease or N3 nodal disease or oligometastatic disease, I think for those patients, there is a significant argument for doing upfront induction chemotherapy prior to chemoradiation. In other patients, I think that, it is, especially early stage nasopharynx patients, it is very reasonable to do concurrent chemoradiation followed by adjuvant chemotherapy in these patients. I think the one thing that we absolutely have to ascertain as you talk to the medical oncologist is to make sure that these patients are going to be robust enough to get that concurrent chemotherapy. Because I think the worst thing that we can do for these patients is that they get induction chemo and get so sick that you're not able to then deliver concurrent chemotherapy during their radiotherapy. That is a big disservice to them. So now for the next part of the talk, I want to talk a bit about what do you treat? And this is where this course comes in, right? So we want to talk about contouring. And as you think about contouring, there are things that we have to be, cognizant of. First things first, clinical exam. I will say this is, no matter how fancy our imaging gets, nothing really substitutes clinical exam in head and neck cancer. So doing a comprehensive head and neck exam, including nasopharyngoscopy in virtually every head and neck cancer patient, is extremely important for you to be able to see where the cancer is as you're designing these treatments. Because there are pitfalls and limitations to every imaging modality where something that looks like invasion for instance, if you're looking at an oropharynx cancer, on a CT, it could look like invasion of the epiglottis. And then when you scope the patient, you realize there isn't really any invasion, it's just mass effect on the epiglottis. And so being able to see the tumor itself is very, very helpful as you design radiation treatment plans for your patients. The other thing that I would say in nasopharynx cancer, where clinical exam becomes really important, is a really, really good cranial nerve exam. I think we all know, and as I will talk about in a couple of lectures, when patients have perineural spread, oftentimes patients only present with a clinical symptom. And you can be 2 to 5 years out before something shows up visible on an MRI or a PET scan. So doing a comprehensive cranial nerve exam becomes really important. Other things to think about with every cancer is really understanding the patterns of spread. How do these cancers grow locally? What lymph nodes do these cancers go into? A really good understanding of anatomy. And then obviously histology. We know that certain cancers have certain predilections, right? Adenoid cystic carcinomas like to crawl along nerves. Melanomas have a high rate of distant metastases. So understanding the histology specific patterns of failure and patterns of spread becomes really important. And then really, when you're thinking of doing radiation in the adjuvant setting, really important to read the operative note carefully so that you can take into account all of the operative findings as you are designing these treatments. I'm still fairly old school. I generally talk to all my surgeons when I see patients in the postoperative setting to get a very good sense of whatever their concerns are. If they're concerned that they scrape the tumor off the clivus or they scrape the tumor off the carotid vessel, I want to know that, even if that's not reflected in the operative note, because that's going to certainly change the way I contour and dose a certain region when I'm treating these patients postoperatively. So in terms of imaging, we talked about, a CT with contrast. When you're doing a simulation, you definitely want to use a contrast, especially if you don't have a diagnostic CT with contrast. And for nasopharyngeal cancer, certainly using MRI and PET scans and being able to fuse them becomes really important. I wanted to show you a couple of examples of how these three modalities really complement each other. So here's a patient with a oropharyngeal cancer where you can see that has a very necrotic node. Here on the CT, you can see then this node on an MRI. This is a T2 sequence where it's brightly hyper intense. But then you can look at the PET scan here, and you can see that you can see uptake here in the submandibular glands. But because this node is so necrotic, there's almost no uptake, very similar to background uptake on the PET scan. So again, you can see that if you were to just look at the PET and not look at a CT with contrast or an MRI, you could easily miss this level 2A node sitting right there. And then dental artifact. I think as we all know in head and neck cancer, this is a nemesis of every head and neck radiation doctor, is dental fillings. And so especially in an era where, a lot of our patients, even here in the US, only get staging CTs and don't always get a PET scan, you can see that it would be very difficult to see this primary oropharyngeal tumor because of dental artifact streaking from the metal here without a PET scan showing you where that tumor is. And then finally, just showing you some changes in volumes. It's kind of this, again, same concept that in an oral pharynx patient, really palpate. If you have a tonsil patient, you want to palpate the glossotonsillar sulcus as well as the base of tongue to make sure that you see, you treat any subclinical invasion into the base of tongue. And this is what this is being reflected here. You can see in blue is the tumor drawn on CT and the MRI here. And you can see that there's uptake. Then on the PET is the green, so it's slightly bigger volume. But on physical examination, there was induration of the base of tongue in this patient. And so you can see that the final GTV encompasses that induration on your physical exam. And then finally, looking here for how an MRI, particularly in nasopharynx cancer, can complement your workup is looking at clival invasion in this patient. So here there's a patient who has a well lateralized T1 nasopharyngeal cancer in the left fossa of Rosenmuller, and here you can see on an MRI that as you go up a couple of slices that there's clear clival invasion in this patient, so it changes them from a T1 to T3. So adequate imaging. Next step, how do you dose these? And I will say that that's the one nice thing about all of radiation oncology. We all follow the same dosing no matter what part of the world we're in, right? So for head and neck cancers, you're going to take the gross disease to 70 gray, and then elective volumes to 60 and 54 gray if you're doing an SIB technique. In my practice here, and for nasopharyngeal cancers, I typically do a 33 fraction regimen, but certainly very reasonable to do a 35 fraction regimen. But now the devil comes in these details. What margins do you give? What do you include around the primary tumor? And so just recently, in 2018, this is a consensus statement published by Dr. Lee, by Dr. Ann Lee, looking at what margin should you put around the primary tumor and the involved nodes for nasopharyngeal cancer. And here are a variety of recent studies across the world. So, US-based studies and primarily then Asia-based studies. And you can see that generally most people put on the order of a 5 millimeter margin around the primary tumor for their CTV70. There are some places that include the entire nasopharynx. But I think the caveat that I want you to take, when you start dealing with T3 and T4 tumors, you can certainly be a little bit more parsimonious on your margins when you know that there is an anatomic barrier protecting the pattern of spread in that area. So you can certainly decrease those margins to 0 to 1 millimeters depending on where you are. And so this particularly becomes important when you're taking care of patients who truly have T4 disease, so patients who have disease going into the cavernous sinus or into the sphenoid wing along the dura. You can really have a much smaller margin to avoid unnecessary irradiation of the adjacent brain in those patients. And then for nodal volumes, again, at least a 5 millimeter margin is reasonable, with the only caveat that if you're treating any extracapsular extension, so if there's any radiographic extracapsular extension, you should perhaps make those margins slightly bigger to account for more occult microscopic disease in that area. This is the holy grail, right? I think this is what we all spend hours and hours, even I, when I contour a nasopharynx patient, this is where the majority of decision-making takes place for me. What am I going to include in that elective area around the nasopharynx? This certainly varies across T-stage, but I think some things remain pretty standard. For all patients with nasopharyngeal cancer, extremely important to treat the entire nasopharynx. Extremely important to cover the skull base. You always want to cover at least the paths of cranial nerves V2 and V3, so foramen rotundum and foramen ovale for all patients. And for more advanced patients, certainly consider extending it laterally to cover the carotid canal and cover the jugular foramen in those patients. Definitely covering the clivus. So if you have no clival invasion, so T1, T2 disease, at least the third or half of the anterior clivus. And if you have T3, T4 disease, you really need to cover the entire clivus. Covering the posterior ethmoid sinus, covering the sphenoid sinus. So for all patients, at least covering the inferior half of the sphenoid sinus, and for T3, T4 patients, covering the entire sphenoid sinus. Covering the cavernous sinus, certainly for T3 and T4 patients, and I think this is where the decision becomes tricky. If you have a T3, T4 patient and you have no obvious disease in the cavernous sinus, are you going to cover unilateral cavernous sinus where you have bulky disease, or are you going to cover bilateral cavernous sinus? And I think so these are decisions that we certainly think of. And then covering anteriorly, so covering the posterior third of the maxillary sinus, and what you really want to do here is cover the pterygopalatine fossa. you want to make sure that you've covered that path of V2 along the pterygopalatine fossa in these patients. Anteriorly, also covering the nasal cavity, so at least covering the posterior 1/3 of the nasal cavity. And if there is any nasal cavity invasion, and I think this is, I'll show you a case. I have actually a patient I just treated for a failure here, where the patient had, invasion, just mild invasion into the nasal cavity, and the treating radiation oncologist covered a very minimal margin on that. And then the patient just failed in the nasal cavity. So if you have any nasal cavity involvement, a good rule of thumb is that you should at least have about 1 centimeter to even 1.5 centimeters anterior coverage beyond where your gross disease is, so that you're accounting for microscopic disease in these patients. Covering parapharyngeal space. So as you're contouring the nasopharynx, you want to cover that lateral parapharyngeal space. You want to go in and really cover the pterygoid, the pterygoid plates in these patients. And oftentimes you're going to cover, the pterygoid muscles. And then inferiorly, oftentimes you're going, down into at least the anterior part of the oropharynx, so covering some portions of the soft palate. And depending on how much caudal disease you have, you may even go down further to cover the tonsils in these patients. A lot of attention to the retropharyngeal space, so covering all the retropharyngeal nodes. So nasopharynx cancer patients are one of the few cancers where I can think of where you're going to cover, just by the virtue of you covering the nasopharynx, you're going to cover both the medial and the lateral retropharyngeal nodes. And it's important to realize that the retropharyngeal space is a very extensive space craniocaudally. Starts literally at the skull base and inferiorly goes all the way down to the hyoid bone. And oftentimes when I'm evaluating plans from other places, this is the area where I see people cheat. They forget that you have to cover that space all the way down to the top of the hyoid. And so oftentimes the medial retropharyngeal nodes go uncovered below C1, C2. And oftentimes patients can then fail there in this. Again, showing you the guidelines here. This is the consensus guide, the global consensus guidelines on coverage. You can take a look that goes over this in more detail. So I am all about pictures, and the rest of my talk is really going to be focused on some pictures so you can kind of get a sense of what you're covering. So here is a patient with very early stage disease. So somebody who has T1, T2 disease. You can see that here, laterally, we're coming all the way and covering all of that retrostyloid space, coming all the way to the mastoid tips here. So you really want to make sure that you're covering that. Posteriorly, you can see in this particular patient that elective volume is covering the entire clivus. In this patient, laterally, again, you can see coming all the way to the styloid process here, coming in and covering that space. And then you can see that all the parapharyngeal space, which is right here where you see these red arrows, the parapharyngeal space is completely included in that 5940 volume. Similarly, cranially, coming up to at least cover the inferior half of the sphenoid sinus in these patients. But when you have a more locally advanced patient, so this is a patient who has clival invasion, you can see that the entire clivus is included in the field here. And you can see that peripherally, you're coming out here to cover all the cranial nerve foramina. So here's foramen ovale bilaterally, and you can see that's being covered. And up here, you can see that the pterygopalatine fossa is being covered. And this is the very top of the pterygoid plates, and you can see the plates are being covered very generously. Again, showing you the same thing here. So again, somebody who has a bulky midline nasopharyngeal cancer going for, really going bilaterally. And you can see that in this patient, even inferiorly, we're covering down to the level of the soft palate. The parapharyngeal fat's covered, the soft palate is covered because there's tumors coming down. And you can see that the entire clivus is covered here in the radiation field. I would say that you can even take this elective volume a little bit more laterally and make sure that you're getting adequate coverage all the way down to the mastoid. So cut all the way down to the styloid process and all the way down to the mastoid, because honestly, there's really no toxicity in adding coverage here, but a failure here can be really devastating in these patients. Again, showing you that same volume here for that elective volume around the nasopharynx. So you can see here somebody who has a fairly small nasopharyngeal cancer with a contralateral retropharyngeal node. Again, showing you the anterior coverage here, covering the pterygopalatine fossa, covering the anterior third of the posterior third of the maxillary sinus, laterally covering all of the skull base here very well in these patients. So how does nasopharyngeal cancer go along cranial nerves? I wanted to try and give you an example. So this is an example of actually one of my patients, very, very locally advanced nasopharyngeal cancer patients who had literally every cranial nerve that you can think of being involved here. So you can see here thickening along V2. So when patients have disease along V2, this is what it looks like. Here's the pterygopalatine fossa. Here's the superior part of the lateral wall of the maxillary sinus, and you can see the tumor spreading along here. Here you can see, again, disease in the skull base, involved in going into the cavernous sinus. And you can see here's that cavernous sinus where you have cranial nerve 3, 4, V1, V2, and 6 involved. And these tumors can, locally advanced tumors, you can see they can then actually, from 6, come across the clivus, get into 6, and then actually can come and grow right along the tentorium cerebelli here. And so you can see this patient actually had disease growing inside the infratentorium, compressing upon the brainstem. So you can see extremely advanced disease here in this patient. And so that's why really, you want to make sure that when you're doing elective coverage, before you see any cranial nerve involvement, that you're very, very generously covering all of that, that skull base in these patients. So again, just showing you some examples of nasopharyngeal cancer and cranial nerve spread. So here's a patient with a nasopharyngeal cancer where the tumor went into foramen ovale, and from foramen ovale went into the cavernous sinus. So you can see that foramen ovale right there. Similarly, another patient with a T4 nasopharyngeal cancer. So here you can see that nasopharyngeal cancer extending into the carotid space, and then coming in intracranially in this patient. So cranial nerve 11 being cranial nerve 12, I'm sorry, being invaded in these patients. So cranial nerve 12 invasion, you can see both through the carotid space and invasion directly into the hypoglossal canal in these patients. Another patient with another very locally advanced nasopharyngeal cancer, you can see here tumor extending into the jugular foramen and carotid space. So you can see this tumor then extended and involved. The patient had 9, 10, and 11 palsies in this patient. Another example of a cranial nerve 6 invasion. So this is, as I mentioned, cranial nerve 6 has 2 distinct ways of getting involved. One is direct clival invasion going posteriorly, or tumor extending into the cavernous sinus and then invading into the nerve. So here's where this is a fiesta image of cranial nerves, a beautiful way to look at all cranial nerves. So you can see this is cranial nerve 7 and 8, and here you can see cranial nerve 6 bilaterally, and there's 6 being invaded here. So here are some volumes just to kind of give you an idea of how generous we usually are at the skull base for these patients. So you can see this is a patient, with a T3 tumor, and you can see generous coverage of bilateral cavernous sinuses, coverage of the entire sphenoid sinus, going into the posterior third of the maxillary sinus in this patient. And then coming down here, again, you can see, covering obviously the gross disease, but then coming down here and again, covering all of that skull base, covering all of that clivus in this patient, covering the pterygoid plates, covering the parapharyngeal space in these patients. And again, more inferiorly here, you can see when you have low-hanging nasopharyngeal cancers, really need to make sure that you're covering the soft palate in these patients, because it can just, the parapharyngeal space is right here, and these tumors can directly travel from that parapharyngeal space and invade into the soft palate in these patients. And then just again, showing you that lateral coverage here, covering the pterygoid, covering the retrostyloid space in these patients. And then these are one of the patients where you can see we always cover level 5s. And my resident, I know we're going to do a talk on level 5 nodes, and this is always a topic of interest of, what cancers do you cover level 5 nodes in? I would say that nasopharyngeal cancers, hypopharyngeal cancers, and terrible skin cancers are the 3 common cancers where these cancers can fail in level 5 nodes. So you can see here are these level 5 nodes. So you're going all the way down to the occipital musculature here. Really need to make sure that, so here's 2A, 2B, and then the level 5 nodes covering here, 5A nodes being covered here. And the 5A nodes are always going to be in your high-risk PTV. So this area is going to usually get 59, 40, 60 gray of radiation. And then once you start coming down to the supraclav lesion, here are your 5B nodes, and these should also be covered for a nasopharyngeal cancer patient. There is now some debate for a node-negative nasopharyngeal cancer patient, should you cover this? And so you could certainly, consider eliminating 5B coverage. But if you have any nodal disease, really, you should cover these level 5 nodes. There is minimal morbidity here. The only thing you're often giving these patients is a little bit more of a posterior occipital scalp haircut, but otherwise you should cover those areas. Modality. So I will say, we have gone from the era of 2D radiotherapy to 3D conformal radiotherapy to IMRT, and now in some places like San Diego, protons. I will say that generally, I think either photon-based radiotherapy or proton-based radiotherapy are adequate treatment modalities for nasopharyngeal cancer. I think that if at all you can use IMRT, I would say this is the only known head and neck cancer disease site that I can think of where IMRT has actually shown to improve local control, primarily due to our ability to cover the disease better. That you should do IMRT. I think protons are certainly a consideration in patients that have T4 disease, particularly, where you may get slightly better sparing of the normal brain and brainstem in those patients. There was this is an MD Anderson study that looked at protons compared to their historical IMRT standards. And what they did find was, while the coverage was very similar, the integral dose to the rest of the normal tissues was better. So the D5 was a lot better. In their experience, they also did find that the use of G-tubes was lower and patients had less nausea and vomiting. You can take this for what it's worth, but as I mentioned, either IMRT or protons are a reasonable way of treating these patients. My patient, as you remember, had T4 disease after induction chemo, so I actually did end up treating them with protons. And here you can see the proton plan. Mind you, so when you're looking at photon plans, usually that blue isodose line is like 30 gray. Here, this is down to 7 gray. So just you can see, you get a very nice rapid dose fall off in this patients. So I definitely sparing more of their brain, definitely some improved sparing of the anterior oral cavity in this patient. But otherwise, really no difference in parotid sparing or any other structures in these patients. Next, how do you evaluate these plans? And so I think, especially in an IMRT era, you really have to, as radiation oncologists, we really have to sit down with our physicists to understand inverse planning algorithms and how they develop plan objectives, how they develop plan prioritization. Because only if you know how they plan will we understand how to evaluate a plan and when to push that physicist or your dosimetrist to do a better plan. So I think that really, for all of us, it's very worthwhile to really spend a couple of hours during the course of your residency to really sit down with the physicists and see how they actually optimize an IMRT plan. And then when you're looking at how to evaluate a plan, you're looking at tumor coverage, you're looking at sparing of, organs at risk, and especially in all cancers, including nasopharyngeal cancers, there's always a balancing act, right? You want to balance the risk of toxicities with the risk of undercovering something and causing a failure down the line. So again, this is international consensus guidelines just published in 2019 for nasopharyngeal cancers. You can take a look of these guidelines. I kind of put them in here for your perusal, particularly for nasopharyngeal cancers. And then I'll show you what we use. So this is basically what my physicists use, and these are basically prioritization objectives. And so we actually sat down with them and created what these objectives would be for all head and neck cancers, and then went in and did a refinement for nasopharyngeal cancers because, obviously our constraints for temporal lobes and our constraints for cochlea and brainstem are a little bit more lax when we're treating nasopharyngeal cancers. Just to kind of show you, it's just a busy slide with the DVH. I spared everything, including the brainstem and the, but you can see that I did take in a T4 nasopharyngeal cancer patient, I did take the surface of the brainstem to 58 gray. But I did spare the core of the brainstem a bit better, but I did, given that I needed to treat intracranially, treat the entire clivus and treat the entire cavernous sinus, the surface of the brainstem did get 58 gray. The one good thing about protons, look at that mean oral cavity dose. This is where protons win every time. It's because you can spare anterior oral cavity in these patients, and that really does matter for these patients. So here's just some of my pearls for nasopharynx. I think that, I see a lot of nasopharynx failures. I will tell you that in San Diego, nasopharynx cancer is not endemic, So I would say that 50% of nasopharynx cancer patients in my practice are actually recurrent nasopharynx cancer patients that come from elsewhere. And these are some of the common mistakes that I see. Oftentimes people undercover the clivus. So I always tell people, if in your original plan, your brainstem point max dose is not 45 to 50 gray for T1, T2, you've done something wrong. And for a T3, T4 patient, if your brainstem surface max dose is not 54 to 60 gray, you have done something wrong. Similarly, for temporal lobe brain doses, for a T1, T2 patient, if your Dmax is not 60 to 65 gray, you're clearly not covering the sphenoid sinus very well. And for a more locally advanced patient, if your temporal Dmax dose is not 68 gray, then you're clearly not covering those well. So I see there's a question, intracranial extension, what dose did you give to the GTV in this area? And what was your max dose for the brain? That's a great question. So I will say, when patients get induction chemotherapy and there's significant involution of the disease, I will still take that gross disease to 70 gray. And I will relax my brain D0.03 cc's to even up to 72 gray. I will consent that patient for temporal lobe necrosis exquisitely. But generally, you will find that most of us in head and neck cancer are never going to want to underdose tumor. And so I will dose the tumor appropriately, but then make sure that I consent patients for either temporal lobe necrosis. I've also had patients where I've had to make a conscious decision to compromise, or to overdose, to go beyond the tolerable dose for an optic nerve when patient had significant orbital invasion. And so I did consent the patient for blindness and an orbital exenteration, but this patient, thankfully 5 years out, I took the surface of the optic nerve to 62 gray as a point max dose because there was intraorbital extension from the nasopharyngeal cancer and the patient is still controlled. So this is one disease where you will have tough conversations. You will talk to your patients when you have to exceed those normal tissue constraints. Having said that, for most garden variety cases, we're going to try to meet those normal tissue constraints.
Dr.
Finally,
Sung.
cochlea. I will talk about, this is one cancer where your cochlear mean dose really needs to be 45 to 55 gray. If your cochlear mean dose is 15, 20, 30 gray, you have not covered the skull base very well. You have not covered the parapharyngeal space very well, and your patients are going to fail there. So I'm going to show you a couple of pitfalls of inadequate coverage. So here's one of those patients for me. So this is a patient that I saw in 2019. She had EBV-mediated nasopharyngeal cancer in 2011, T3 and 2. And for whatever reason, the treating radiation oncologist actually did a hyperfractionated regimen. Not the wrong thing to do. I do a lot of hyperfractionation in re-radiation. I typically don't do that in de novo radiation. But this particular radiation oncologist chose to do that. That patient got concurrent weekly platinum, and then she got adjuvant 2 cycles of platinum. And then in 2019, she presented with bilateral cranial nerve 12 palsy. That's how she came into presentation. And you can see that this patient has a recurrence in the nasopharynx and a recurrence in the clivus. And coming along, and she also had disease in the hypoglossal canal. I went back and I reviewed the prior radiation plan, and it was clear to me that it was a T3 patient and the person had not covered the clivus very well. They had only covered the clivus for gross disease and had spared the remainder of the clivus. There was no extension of that 60 gray volume to cover the entire clivus. Also laterally, the parapharyngeal space was not covered very well and the skull base was not covered very well. So all the cranial nerve foramina laterally were untreated, frankly. And that's why this patient failed along those lines. Again, to kind of show you that this is that same patient, this is a sagittal MRI. So you can see this big recurrence here going into the skull base. And I did re-irradiate this patient. She was 8 years out from her prior radiation. So I gave her full dose radiation. And as I mentioned that when I do re-irradiation, especially if I'm doing big volume re-irradiation, and what I'm not showing you in here, this patient also failed in bilateral level 1B and 1A nodes. And so I treated both the regional level 1 nodes and this nasopharynx recurrence, and I gave that 72 gray and 60 fractions BID with weekly platinum. She had had profound hearing loss already from her prior platinum, so couldn't do bolus platinum. And then you can see she had a CR to re-radiation. So I will say, never be afraid of re-radiation. It's something that you are going to do a lot of if you're a head and neck radiation oncologist, but you have to do that diligently in these patients. Next case right here is a patient with another nasopharyngeal cancer, so a T3N2 nasopharyngeal cancer, a young man, 58-year-old man, who basically, this was not EBV mediated, it was HPV and EBV negative. Again, then got standard fractionation radiation, 69.96 grain, 33 fractions. This patient had a prior renal transplant, and so this patient got carbo instead of platinum. And this patient got no adjuvant or induction chemotherapy. And then 4 years later, this patient recurred in the nasal pharynx, recurred in the nasal cavity, recurred in the clivus, and it was going into the sphenoid sinus. So again, to show you that, here's that recurrence, nasopharyngeal recurrence going into the nasal cavity. And then up here, you can see going into the sphenoid sinus and going into the clivus here, right here. And so on review of that plan, the treating radiation oncologist had only treated gross disease and had not done any elective coverage of the rest of the nasopharynx or the pterygopalatine fossa or the nasal cavity or the clivus or the sphenoid. And I think this just represents what happens when you don't cover these patients. So again, this patient, I did go back and retreat them with protons, and you can see that that's their plan, and you can see this is the outcome. So this is a patient, now 9 months out since finishing treatment and has had a CR, a complete CR to therapy. I'm going to stop this talk here for the sake of time and just tell you, I'm going to go right to the end. We'll save the toxicities for a different talk, but I do want to kind of just tell you where we're going with this course. We want to talk about normal tissue sparing. We want to talk about what to cover and what not to cover. We want to talk about toxicities. And so our goal for the rest of this course is, as you go through each of these contouring sessions, is that you will see the impact of your contours on outcomes and toxicities in these patients. And what I would like for you guys to do as you go through this course is really take your clinical decision-making and use it to design your contours and looking at your treatment plans and designing your treatment plans and doing your plan evaluations. And know that the way you plan and the way you evaluate your plan has significant impact on the clinical outcomes for your patients. We're hoping that this course is really going to be an iterative process. Please ask questions of all of us. I know what I'm gonna try to do is copy this Zoom group chat and then write back to you all and answer any questions that you have. And again, thank you very much for your time.
Thank you very much, Dr. Sanghvi.
Ben, I can come and probably, if there's enough time, I can do another session sometime and finish the other half.
Okay, excellent. I think everyone would love that. And before we wrap up, there was another question that came up. This was, in what situations would you include the whole nasopharynx?
Yeah,
in
that's
the
such a great
CTV-70?
question. So I would say that I always include the entire nasopharynx to 60 gray. But when would I include the whole nasopharynx to 70 gray? So I think this is certainly, I will say that in patients who have a really bulky primary tumor that involves the bilateral nasopharynx, including midline. So those are patients where I think of treating the entire nasopharynx to 70 gray, just to make sure that I'm covering the nasopharynx and that parapharyngeal space at least to 70 gray. Really, that would be the one setting where I think of them, think of covering.
Excellent, thank you. And for, would it be helpful for the residents in the Philippines on this call if we sent you these lecture slides?
Yeah, hopefully I'm in favor of that. They should get the slides.
Quick thumbs up if yes. Okay.
Yes, okay.
And also, this is one thing we're trying to do with Rayos Contra Cancer, but we're also saving these presentations as recordings. I know there's a lot to fit in 1 hour, But some of those points that he made during the case discussions, I think, are real gems. So we'll also try to send a video of each session and maybe even put it on YouTube, and you can watch it in slow motion.
Right, yeah.
Okay, Dr. Sangvi, it looks like people are saying yes and thank you. If anyone has